You're called to a patient with severe thirst and passing large volumes of urine. They're dizzy, dehydrated, and confused. Could this be diabetes? Not necessarily the one you're thinking of. This is diabetes insipidus, a condition caused by the body not producing enough antidiuretic hormone, ADH, or the kidneys failing to respond to it. This causes excessive thirst, water consumption, and urination, and involves the normal blood glucose level. With a prevalence of approximately 1 in 25,000, this is a rare disease. It can present at any age, with males and females affected equally. Paramedics need to understand this presentation, as patients can deteriorate quickly and a misdiagnosis can lead to severe hypotension, electrolyte imbalance, decreased GCS, heart arrhythmias, and more. To understand this condition, it is important to know the normal pathophysiology of ADH. ADH, also known as vasopressin, is a peptide hormone that is made in the hypothalamus. It is stored and released from the posterior pituitary gland. ADH helps to maintain the homeostasis of plasma osmolarity and blood pressure. Osmoreceptors detect an increase in plasma osmolarity and baroreceptors detect a decrease in blood pressure, stimulating the brain to release ADH from the posterior pituitary to travel through the bloodstream and act on the kidney collecting ducts. ADH works by binding to V2 receptors on the basolateral membrane of principal cells. This activates G proteins, causing an increase in cyclic AMP levels and activating protein kinase A. Protein kinase A phosphorylates proteins, which trigger the insertion of aquaporin 2 channels into the apical membrane. The increased aquaporin 2 channel expression means water can now flow from the urine into the cell and across the blood through aquaporin 3 and 4 channels. Increasing water retention helps to concentrate urine, hydrate the body, stabilize plasma osmolarity, and maintain blood volume. In diabetes insipidus, the ADH aquaporin pathway is disrupted. This means the kidneys fail to concentrate urine, resulting in polyuria, a condition where large volumes of hypotonic, dilute urine are excreted. Hypernatremia, where the concentration of sodium in the blood is above 145 millimoles per litre, can occur due to the amount of water loss being greater than sodium loss. This causes cellular dehydration, especially in the brain tissue, and can alter conscious levels. There are several types of diabetes insipidus. Neurogenic diabetes insipidus, also known as central diabetes insipidus, is where inadequate ADH is released from the posterior pituitary. It can be caused by traumatic brain injuries or base of skull fractures near the pituitary stalk, tumours in the pituitary gland or hypothalamus, neurosurgery, autoimmune diseases, or a genetic mutation of the AVP gene. Around 40% of cases have occurred following surgery of a ruptured anterior communicating artery aneurysm. With limited ADH release, there is no insertion of the aquaporin 2 channels to make the collecting ducts more permeable to water, so water can't be reabsorbed back into the bloodstream. Neurogenic diabetes insipidus should be considered if a patient presents with polyuria and dehydration post-head injury or neurosurgery. Nephrogenic diabetes insipidus occurs when the kidneys fail to respond to ADH. The V2 receptor binding fails, meaning there is no cyclic AMP cascade and no increase in aquaporin 2 expression. ADH levels will be normal or high. Some causes include an X-linked mutation in the V2 receptor gene or the aquaporin 2 gene, taking drugs such as lithium or democlocycline, metabolic disturbances including hypercalcemia or hypokalemia, and chronic kidney disease. Paramedics should consider nephrogenic diabetes insipidus in patients who are on lithium and have sudden dehydration or polyuria. Gestational diabetes insipidus occurs in late pregnancy due to the placenta producing vasoprenase, an enzyme that breaks down ADH. This increases the metabolism of ADH, resulting in low levels as it's being destroyed faster than it's being secreted. Paramedics should consider this in pregnant individuals with unexplained dehydration, polyuria, and no excessive glucose in the urine. Primary polydipsia, also known as dipsogenic diabetes, is not truly diabetes insipidus as the osmolarity and ADH pathways are still intact, but instead mimics the symptoms. Primary polydipsia occurs when excessive fluid intake causes the brain to signal to the posterior pituitary to suppress ADH release, resulting in polyuria. Psychiatric illness is a cause. It's important to remember that not all causes of polyuria and polydipsia are diabetes mellitus or diabetes insipidus. Diagnosing diabetes insipidus in the pre-hospital setting cannot be done, as it involves many tests that can only be done with further assessments outside of a paramedic scope. However, looking for the signs and symptoms can aid with a differential diagnosis. Polyuria and polydipsia with a blood glucose level that is in the normal range are the key manifestations of diabetes insipidus. It is characterized by a high hypotonic urinary output of more than 50 ml per kilo of body weight in 24 hours, associated with polydipsia of more than 3 litres per day. Confusion, arrhythmias, seizures, and coma may arise from hyponatremia or electrolyte disturbances. Hypotension and tachycardia may occur due to hypothermia. Dry mucous membranes, headache, and dry skin with reduced elasticity may occur due to dehydration. Gathering a thorough history is important. Patients in the pre-hospital setting may have already been diagnosed with diabetes insipidus. It should be considered in patients with a history of trauma, neurosurgery, medications containing lithium, family genetics, and pregnancy. Hypotension, shock, and electrolyte imbalances are the greatest risks of diabetes insipidus, as they can result in decreased perfusion and organ damage, so they should be prioritised in treatment. If the patient is conscious and able to drink, ensuring easy water access enables adequate fluid intake and reduces polydipsia. Isotonic fluids such as IV saline are often used by ambulance services to treat hypotension with a systolic blood pressure below 100 milligrams of mercury. Serial ECGs and GCS statuses should be completed to monitor for any arrhythmias or neurological effects, and a BGL should be taken to rule out diabetes mellitus. The patient can deteriorate rapidly, so rapid transport is vital. IV saline is hypertonic and contains large amounts of sodium and chloride, which can worsen hyponatremia and put strain on the kidneys in diabetes insipidus. Dextrose-containing IV fluids, such as 5% dextrose solution, are commonly used in hospitals to treat diabetes insipidus. They are hypotonic and help to correct hyponatremia by diluting the plasma sodium concentration while also increasing blood volume and hydration, making them a more appropriate treatment. Whilst not currently used in any Australian paramedic guidelines, this may be a more appropriate treatment for future paramedic practice. Desmopressin is a synthetic analogue of ADH with a longer half-life that binds to V2 receptors on the kidney collecting ducts to promote water reabsorption. This drug is useful for patients with neurogenic or gestational diabetes insipidus to increase the amount of ADH available for use. It could be administered orally or intranasally and could potentially be used in the future pre-hospital setting as a life-saving intervention for severe cases. Whilst not currently available for paramedics to use under Australian guidelines, it is important to know that desmopressin is not a treatment for nephrogenic diabetes insipidus, as the issue is not with the amount of ADH available. In summary, diabetes insipidus is where the body does not produce enough ADH or the kidneys fail to respond to it. This results in an inability to retain water and concentrate urine. Patients presenting with polyuria, polydipsia, dehydration and confusion could have diabetes insipidus. A BGL should be taken to rule out diabetes mellitus. Renal and neurological complications could also present with similar symptoms. Patient history gathering is vital, and diabetes insipidus should be considered in patients with polyuria, as well as recent head trauma, surgery, lithium use and pregnancy. Treatment includes monitoring for hypotension and an altered GCS, as well as administering fluids and rapid transport. Diagnosing can be difficult in the pre-hospital setting, but recognising the signs and stabilising the patient can make a critical difference for the overall outcome before hospital treatment can begin.